Okay, hi everyone. Thank you so much for joining this Becoming a Doctor session. So this is an ECG masterclass. We're lucky to have Dr. Ben Lovell with us. So in a moment, I'll just pass it over to him, but just explain the house rules. The same for all the sessions. If you're in the Zoom, if you have any questions or comments about what Ben is showing right now, put them in the chat. If you have any questions that you feel can wait till the end of the session, put them in the Q&A box. During the session, Ben will ask a lot of questions about whether it's ECG or things like that. For those, just private message him the answer, and then he'll see them, and that gives everyone a chance to be able to answer on their own without feeling any pressure from seeing other people's answers. On the Facebook, again, questions, comments, feel free to chuck them in, and Ben will get to them when he can. But that's all the house rules. I'll pass it over to you, Ben.
Thank you very much. My name is Ben Lovell. I am a consultant in acute medicine. I'm an honorary professor of medical education. I work in London. And what I'm going to talk to you about over the next hour is a masterclass, if I may say so myself, in ECGs, moving from novice to expert. And I suppose the real title of this session is Everything You Wanted to Know About ECGs But Were Afraid to Ask. So we're going to start with basic stuff, which I'm going to assume you know it's the very basics, and then we're going to build on it. And the thing about what I'm going to show you is I'm going to try and get your eye into pattern recognition. And you get pattern recognition by looking at a lot of ECGs. And today we're going to look at 30. So you can count them. Along the top, there is a counter. We're going to go up to 30 ECGs. So I'm going to get you a good way towards being able to look at an ECG. We talk about eyeballing an ECG and then being able to make a very rapid assessment. Disclaimers. So we're going to move from the top of this little note to the bottom. Or rather, we're going from the bottom to the top. So you might look at an ECG now and see bits and wavy bits, funny squiggles on a pink background, but not quite sure of all of the mysteries contained therein. I am going to hold these mysteries up to the light and unravel them for you, and they will be mysterious no longer. We'll revisit this at the end. I'm making some very bold claims here, and hopefully you'll be along with me for the ride and you agree. So let's start with the basics. ECG number 1 of 30, the normal ECG. We read our ECGs like we read, going from left to right. We do not read our ECGs right to left, even in countries that read right to left, like in Arabic or Hebrew. Everyone goes left to right. So that is how time moves. Each QRS complex is a heartbeat. And different parts of the ECG look at different parts of the heart. We've got lead 2, lead 3, and AVF, which look at the underneath of the heart, the inferior aspect, which is mostly right heart, right ventricle. A lot of the electricals or the electrical pathways are here. And its blood supply is the right coronary artery. Broadly speaking, V1, V2, and V3 are looking at the anteroseptal parts of the heart, which is mostly left ventricle, the main pump. And the blood supply is usually mostly the LAD, the left anterior descending. And then we've got V4, 5, 6, which look at the anteroseptal side of the heart. And their blood supply is a mixture of the LAD and the posterior circumflex. And yet I've left 3 uncovered, but we're not going to go into those today. These are the main areas of the heart you're going to look at when we're trying to decide whether particularly blood supply problems. A normal complex, a heartbeat on the ECG, is a P, QRS, T complex. The P wave, atrial depolarization, QRS, ventricular, and then T wave is ventricular repolarization. I told you we're going to start very basics. We'll get more complex than this. To know when things go wrong, you have to understand what normal things look like. So the PR interval goes from the beginning of the P wave to the beginning of the QRS complex. And this should be no longer than 200 milliseconds, which is 5 small squares. Any longer than that, you have first degree heart block. The QRS complex should be no greater than 120 milliseconds. That's 3 small squares. Any greater than that, and you have a bundle branch block. And the QT interval, which goes from the beginning of the QRS complex to the beginning, not the end, of the T wave, should be about 150 to 160 milliseconds. Although I rarely get too agitated unless it goes above about 500. And you can't really use the number of squares for this. You have to calculate it either because you know the equation or you know where to look at the top left side of the ECG where it will tell you the QTC, the corrected QT interval. And that's affected by medications and electrolyte disturbances. So let's start with the first session, which is chest pains, blood supply to the heart. Have a look at this ECG. We're not talking about rate or rhythm problems at the moment. We're talking about blood supply. What is the blood supply problem to this heart? Well, hopefully you can see the main problem here is in leads 2, 3, and AVF. We said earlier, these are the inferior leads, looking mostly at the right heart, the inferior heart. And we can see the ST segments don't look right. They look elevated. Now, a lot of people get a bit confused when they look at ECGs and they say, well, you say this is ST elevation, but then this guy over here says it was high takeoff, and I don't really know what that means. And how do you know the difference? Well, pattern recognition. In the limb leads, which is leads 1, 2, 3, AVR, AVF, AVL, ST elevation looks like snails. I call it snailing. No one else calls it snailing, just me. So don't say this in the workplace, the patient's snailing, but I do say this. So when I see snails in the limb leads, classic ST elevation MI, a STEMI, an inferior STEMI. This is the main problem on this ECG. I bet this patient has a lot of chest pain. And then we can look at some of the other leads and say, well, maybe there's a bit of ST elevation, there's a little snail in V6, and they drop their T waves in V1, 2, and 3, so a little bit of ischemia there, but the main problem is a STEMI. Have a look at this one. Look at the ST segments. We're talking about blood supply. We're talking about a patient who's coming with chest pain. Well, we have some very marked ST abnormalities, and they're mostly in V2, V3, V4, V5, a bit of V6 as well. And you'll notice this is a STEMI, and STEMIs in the chest leads, the V leads, don't all look like snails. In fact, a lot of them look like tombstones. And you may have heard this phrase. This isn't just a me thing. A lot of people call this tombstoning. The patient's got chest pain and they're tombstoning on their ECG. And a tombstone appearance is how you can spot ST elevation in a chest lead. Have a look at this one. We're talking about a patient with chest pain. No marked snails or tombstones, but there are some ST segment abnormalities in V4, V5, and V6. They've gone down. So this is ischemia, not a STEMI. Could be an NSTEMI, could be an infarction, but it's not a STEMI. And this is important because in the UK, at least, people with STEMIs get directed straight to the cath lab, whereas people with NSTEMIs tend to be directed more towards people like me in acute medicine for medical management before they have a more considered diagnostic discussion with cardiologists and maybe the next day. But you can see the ST depression. Any questions, pop them in the chat box. How are we going to know the difference between a STEMI or an NSTEMI? Sorry, an infarction or ischemia? We're going to do a troponin level. And that's really all I wanted to say about chest pains, which I think are quite simple. Could that be a posterior STEMI, someone is asking me? Okay, so posterior STEMIs is an excellent question. Let me go back to it. So posterior STEMI, you normally would look at by picking up this paper ECG, flipping it up to the light, holding it upside down and backwards, and seeing whether or not you had the V4, V5, V6 depression actually looked like it could be ST elevation. It's hard to imagine looking at this one. I don't think it could be a posterior STEMI because normally you would get a very deep, well, actually it could be. I was going to say you get a very deep Q wave preceding the ST elevation, but it could be. And the best thing to do, rather than be holding things up to the light, is simply get the ECG stickers and put them in the same place on the back of the chest and see whether you have the same ST segment elevation on that side. And another question is, do all STEMIs have reciprocal depression other leads? There's no all or never in medicine. So the answer is no. A lot of them do have reciprocal depression other leads, but it's not part of the diagnostic criteria. You can just have ST elevation in one area and that's it. And that's all I really wanted to say about ischemia because I think it's one of the lesser interesting things about ECGs. We're going to go on to some more exciting stuff now, which is going too fast and going too slow. But I have one more question. What's the reason that ST elevation occurs? Okay, this is a very complex answer, which is slightly out of the scope of this lecture, but it's usually to do with the way that the LV septum depolarizes when it becomes ischemic, and how it tends to shift its depolarization pattern towards the lead, and therefore the ST elevation goes up. And that's all I'm going to say about it, because that's all I know about it. So let's talk about tachyarrhythmias now. And I think tachyarrhythmias tend to get people a little concerned, but you can actually make a very, very easy work of them by categorizing your tachyarrhythmias into a simple 2x2 box. I'm just looking at the chat. Why does lead 2 trace look so weird? Chelsea would like to know. Okay, let's go back to lead 2 and I will answer the question. Is it because I've cut it off? Because you can't quite see the front of it? It doesn't look so weird to me. The patient has a normal access. They've got a very, very small flat T wave in lead 2, but I wouldn't say it was so weird. I'm going to move on now. Resume share. So we're going to go into tachyarrhythmias. This is how you can look at a tachyarrhythmia on an ECG and work out what it is, make the diagnosis. And you're going to do it by considering whether it's regular or irregular, and whether the QRS complex is normal or wide. A wide QRS complex is always abnormal. And I'll show you how we're going to do that. Have a look at this ECG. What is the rhythm? So it's fast. The rate is about 150 beats a minute. And we want to know whether it's regular or irregular, and whether the QRS complex is broad or narrow. Well, let's do the QRS thing first of all. The QRS complex is normal, narrow. We said a broad QRS complex is more than 3 small squares. So we've got a narrow QRS complex. Is it regular? Well, it looks pretty regular to me. However, let's be certain about it. Look at the RR interval over here. It's not quite the same over there. Definitely not the same here. Not so much there either. I think the RR interval changes beat by beat. I think this is an irregular rhythm. Maybe you've seen people in the workplace take a bit of paper and pencil and they've marked off a little dash on the paper where their QRS complexes lie and then move them along one to see whether they match up. Because a sinus regular rhythm is pretty regular. I think this is irregular, normal QRS complex tachycardia, which makes it atrial fibrillation. Atrial fibrillation with a fast ventricular response. And in fact, in between the QRS complexes, you can see that there is no clear P wave because the baseline rhythm is fibrillation. So we're going to put atrial fibrillation over here, an irregular rhythm with a normal QRS complex. Straightforward so far. Have a look at this one. Is the QRS complex normal, narrow, or is it broad? It's nice and narrow. Is it regular or irregular? Now you can see with this one compared to the previous, this is a nice regular rhythm, clockwork. So you've got a regular narrow complex tachycardia, which is going at about 150 beats a minute. Sinus. The reason I know it's sinus because it's going to look at V1 and V2. These are the best leads to see P waves in because your sinus node sits very close to V1 and V2. And you can just appreciate there is a T wave and then a little P wave afterwards. A nice regular tachycardia, sinus tachy. We'll put that over here in a normal QRS complex with a regular rhythm. So far, so good. What about this one? QRS complex, is it normal, narrow, or is it broad? That is a weird looking broad QRS complex. Is the rhythm regular or irregular? Now, at first glance, you might say, well, how am I supposed to know? It looks so weird. But okay, let's take it easy. Let's look at the points in the lead 2 along the bottom. We can see there is a regularity to it. It seems to be about 160, 170. It's a regular, broad complex looking tachycardia. This is VT, ventricular tachycardia. If an electrical impulse arises from within the ventricles rather than coming down the normal route from the sinus node, that QRS complex looks weird. The ventricle generates very weird looking broad QRS complexes. So we can put VT in our box over here, and the VT is a dangerous rhythm. VT may not have a pulse. So he appears in dangerous flames because it's all very scary. And remember that VT is one of your shockable rhythms. So someone who has got VT may have a pulse but look very unwell, or they may have no pulse at all, in which point you need to do a shock, need to give them a shock as quickly as possible. So that's our third box. And I'm going to introduce you to 3 laws of tachycardias, which will guide you well. And the first law of tachycardias is if you have a broad, complex, regular tachycardia, always think, is this VT? And the reason we think that first of all is because VT is dangerous. And it may kill you. If you have a pulse with VT, you often won't have one for much longer unless you act very quickly. So that's the first law. We'll come back to it. It'll have relevance. Have a look at this one. So you want to know, is the QRS complex broad or narrow? Well, it looks broad. We can't quite see the small squares, but I'll tell you that the QRS complex is about 130 milliseconds. It's more than 3 small squares. It's a broad QRS complex. Is it regular or irregular? It's irregular. You can see that quite clearly. So we have an irregular broad complex tachycardia. What could this be? This is atrial fibrillation in someone who's got bundle branch block. And that will go over here in our irregular wide QRS complex. So if you have atrial fibrillation, if you already have a bundle branch block, a left or a right bundle branch block, which I am going to cover in this talk later on, then whenever you go into AF, you will have a broad complex. So broad complexes can either be generated from the ventricle, such as in VT, or they could be coming down via the usual route from the sinus node, but going through a bundle branch block problem. So they appear broad. Those are the 2 reasons. And that's why I say my first rule is if you have someone with a regular broad complex tachycardia, always assume that it's a VT first until you know otherwise. Don't assume probably just sinus with a bundle branch block, because you might miss a potentially life-limiting condition. So far, so good, but we've missed a few tachycardias out. I'm going to do a very quick dip into the chat room because here we have some questions. Is AF always irregular rhythm? Or if it was regular, would it be a sinus tachycardia? AF is always irregular, always irregular. Sometimes you could be on the fence about whether it looks regular or not, but if you check very cautiously by maybe doing the dash method on a bit of paper, then moving it along, you will see that the RR interval is different between every beat. Because basically, the atria are full of chaotic electrical signals, and every now and then a chaotic electrical signal escapes through the AV node and fires off into the ventricles and generates a QRS complex, but it happens on an irregular basis. Could it be AF with an accessory bundle? We will talk about accessory bundles a bit later, but the answer is it didn't look like a delta wave to me pre-excitation, but maybe this will be clearer by the end of the talk. And to clarify, a QRS of less than 3 small squares is normal, asks Suki, to which my answer is yes. So going back into the slide, what about this one? So we have here a looks regular, very regular tachycardia. And is the QRS complex broad or is it narrow? It's narrow. It's about 2 small squares. So we've already said that we know that a narrow, complex, regular tachycardia is sinus tachycardia, but this is a little bit different. This is an exactly 150 beat per minute tachycardia. So what we can sometimes do, if you are not quite sure what the underlying rhythm is in a tachycardia, is you could try slowing it down. If you have your favorite rate slowing drug, you can do this at the patient's bedside if they are on a monitor. Let's give the patient a beta blocker. Let's give them 5 milligrams of metoprolol IV. Why not? Slow it down and let's see what happens. We've slowed it down, blocked the AV node a bit, and look what we have revealed. We have revealed that the underlying rhythm is this very bizarre, jagged up and down bass line. Doesn't look like P waves to me. So what could it be? It has a saw-tooth appearance, the teeth of a saw. This is classic atrial flutter. And here, now we've slowed it down with the beta blocker, we can see it's atrial flutter with a 3-to-1 conduction. You get 3 sawtooth waves, which is what, flutter, 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 QRS. And finally, after 3 flutter waves, one gets through to the ventricles and generates a heartbeat and a QRS complex. So you say, well, Ben, how did you know that that was something to slow down and check? How do you know that was flutter and not a sinus tachycardia? I'll tell you why. We're going to put atrial flutter over here in this box as a regular rhythm with a normal QRS complex. And we're going to say that atrial flutter has a sawtooth baseline. And the reason why I was suspicious and I wanted to slow that rhythm down to see what the underlying rhythm was is because I'm operating under my second law of tachycardias, which is if you see a regular tachycardia at 150 beats per minute, it's usually atrial flutter with a 2-to-1 block. Why? Because when someone goes into atrial flutter, they nearly always go into atrial flutter with 300 flutter waves per minute. And that happens around the world. Big, small, fat, thin, young, old. People always go into about pretty much 300 flutter waves. So if you see a tachycardia at 150, they're probably in atrial flutter with every other flutter wave getting through. And that is the second law of tachycardias. I'm going to dip into the questions for a second. Is this the same with Wolff-Parkinson-White? No, and I will talk about Wolff-Parkinson-White and pre-excitations and accessory bundles later on in this talk. I know people get very excited about it. Isn't it about 1 to 4, not 1 to 3, because the ventricular rate is roughly 75 beats a minute there? I can check. The ventricular rate is 300, 150, 175, 300, 150, 175. It looks like 3-to-1 to me because I'm counting 3 flutter waves. Going forwards. So we've put it over here. And now what is this one? So we have got a tachycardia. We've got a tachycardia with a QRS complex, which is narrow, normal, regular or irregular. Very regular and very fast. Over 200 beats a minute. Now you're going to say, well, Ben, we've already got two rhythms, in this box for regular, narrow, complex tachycardias. We've got sinus, we've got atrial flutter. What else is there? This is something called supraventricular tachycardia, which is a pretty poor name. It's more of a description than a name. It has another name, I'll tell you in a sec. But supraventricular tachycardia looks like a very, very, very fast, narrow, complex tachycardia. And this is why it happens. This is the electrical circuitry of your heart. You've got your sinus node at the top. You've got little internodal pathways. You have an AV node, then the AV bundle, the bundle of His, which is what links the atria to the ventricles. The ventricles are supplied by the bundle branches, the left bundle branch going to the left ventricle, the right bundle branch going to the right ventricle, with Purkinje fibers spreading the signals out into the ventricles. And we know that a normal heartbeat is due to an impulse which is generated in the sinus node, travels down to the AV node, and then travels south through the bundle branches into the ventricles, causing contractions as it goes. In supraventricular tachycardia, you have this problem. Let's look at the AV node. It's an AV node problem, and we look at it under a microscope. And what happens is the sinus node fires off a beat, as usual. The beat goes down into the AV node, and it gets stuck. And what does that impulse do? It simply goes flying around the AV node very, very fast, caught in a tiny little microcircuit, trapped like lightning in a bottle. And every time it spins around this tiny microcircuit, it fires off an impulse down to the ventricles, very, very fast. And that's what SVT is. SVT's proper name is AVNRT, AV node reentry tachycardia, but that's a bit of a bother to say, so most people call it SVT. And that's why we can treat SVT by blocking that tiny microcircuit in the AV node. We do that with a drug called adenosine. It's a circuit breaker. It simply switches off the AV node, terminates that microcircuit, and allows normality to recur. And this is what it looks like on the ECG. You can see on the left, someone is in SVT, very, very fast. They get a big slug of adenosine intravenously. All of a sudden there's a pause, a blip, and then normal sinus rhythm occurs. So supraventricular tachycardia, and we're going to put this as our final tachyarrhythmia, which goes in this box as a regular rhythm with a normal QRS complex. And we know it's not sinus because it has no P waves. You can't see the P waves because all you're seeing is this tiny microcircuit. And it's different from atrial flutter because it doesn't have the sawtooth appearance of the flutter waves when you slow it down. And this is how we differentiate our tachyarrhythmias. My final third law of tachycardias actually comes from the Resus Council's guidance about how to manage unstable tachycardias. And it's if a patient has any of those tachycardias in any of those boxes and is becoming unstable. Unstable means hemodynamically unstable. That means they're dropping their blood pressure. They're dropping their conscious level. They're getting chest pain because they're not perfusing their myocardium. They need to be DC cardioverted. Quickly put to sleep and then a shock to reset the tachycardic heart. And that's it for tachycardias. Let's move on to bradycardias now. Quick check of the chat box, and there are no questions, so I shall move on. Going too slow. So here is our schematic of the heart electricals again. So I've got one quick question. How do vasovagal maneuvers stop SVTs? That's a great question. A good vagus simulation does the same thing as adenosine. It switches off the AV node for a few seconds. The Resus Council will have you believe that about 40% of SVTs are terminated by a good vagal maneuver. So trying to force air out with a closed glottis, although that's not been my experience in real life, but it has exactly the same effect as adenosine. The vagus nerve depresses the AV node and terminates that tiny microsecond. But let's look at our schematic of the heart again. This is our electrical pathways in the heart. Now, imagine if you were unfortunate enough to have developed disease of your sinus node. Maybe you had an infarction and you wiped out the whole bit of that circuitry. Maybe your doctor gave you a little bit too strong a dose of digoxin or beta blocker or something, but your sinus node stopped working. What happens to your ECG? What happens to your heart? What happens to you? Well, you might look like this. This is your basic sinus bradycardia. We know it's sinus because there's a little P wave, which is the sinus node firing, initiating a heartbeat. And then it spreads down and causes a QRS complex, which is the ventricles depolarizing. Then it'll pause, and then the T wave as the ventricles repolarize again. And then it starts over again. But this is a slow heart, sinus brady. And we see this quite a lot in people who have very ischemic heart disease, or they're on some rate-slowing medications. This could happen instead, though. So here we have a bradycardia with no P waves. Where is this heartbeat coming from if the sinus node is dead? And sometimes the sinus node dies. You have a big MI and wipe out your sinus node and it's gone. What happens to you? You have to rely on your backup pacemaker, and you have one. Your main pacemaker is your sinus node. But if your sinus node's out of action, you rely on your backup pacemaker, and your backup pacemaker is your AV node. Your AV node can initiate heartbeats. It's not a great pacemaker. It usually can only pace about 50, 60 beats per minute, but it'll do it in a pinch if you need it. It'll come into action. And you can see that's happened in this patient. No P waves, and they've got a bradycardia. This is called a junctional rhythm. We call it junctional because the AV node sits on the junction between the atria and the ventricles. You might also see it called an AV nodal rhythm, or just a nodal rhythm. And it's a type of bradycardia when your sinus node is out of action. What happens if you have horrible disease of your AV node and signals are being initiated by the sinus node, but they can't pass down to the ventricles? Well, you might end up with an ECG like this. It's brady, it's slow. Look at the P waves. I've marked them on here for you. P waves are in some funny places. On the left of the screen, there's one right before the QRS complex where it belongs. Then there's a P wave that doesn't really go anywhere. And then there's another P wave, which is a QRS complex that follows. A P wave hidden in the T wave, another one. So what is going on in this ECG? We've got our P waves mapped out and they look regular. So the sinus node is firing regularly. It's marching regularly through its business. The QRS complexes are occurring regularly, but there doesn't seem to be any relationship between the P waves and the QRS complexes. If we remove the ECG and look at them, it's not as if there's 1 or 2 or 3 P waves for every QRS. There's been complete dissociation between the two. This is called complete heart block. Heart block, also known as AV block or AV nodal block, means that the AV node has died. So the P wave, the sinus node, is firing. The ventricles are contracting, the QRS complex, probably generated just south of the AV node, but they cannot see each other and they cannot interact with each other. I'm going to tell you a love story now. And it's the love story of the AV node. And it's a way of remembering the different types of heart block, of AV nodal block. And a normal heartbeat, the P wave and the QRS complex are in love. And they go everywhere together. Wherever the P wave goes, the QRS is there, and they're never apart. In first degree heart block, AV node block, where there's been a bit of damage to the AV node, the P wave and the QRS complex still go everywhere together, but a bit of distance has appeared between them. They are no longer as close as they once were. And you'll notice that in the ECG as a long PR interval, more than 5 small squares, more than 200 milliseconds. Second degree heart block has 2 parts of it, depending on how diseased your AV node is. Second degree heart block is worse than first degree, obviously. And it's got 2 forms, Mobitz 1, Mobitz 2. Mobitz 1, what you will notice is that the PR interval gets longer with every heartbeat until a QRS complex is dropped. And what this means is that the QRS complex is coming home later and later every night after work until eventually one night it doesn't come home at all. And that's when your QRS complex is dropped. If things do not improve, you end up with Mobitz 2 second degree heart block. And this is where the QRS complex is only coming home 2 or 3 nights a week or every 3rd night, and you've got a fixed block between the P wave and the QRS complex. And finally, in 3rd degree or in complete heart block, there's absolutely no relationship at all between the P wave and the QRS complex. And in fact, the relationship has completely fallen apart. And this is how I teach the ways to remember the types of heart block. Let's go back to AV nodal disease. I'm going to do a quick drop into the chats. What's the difference between defib and synchronization? Defibrillation is where you are switching off ventricular fibrillation, VFib. You defibrillate. It's what you do in a cardiac arrest due to VF. Synchronization is what I'm talking about as my 3rd law of tachycardias, where someone is going in a fast, unstable heart rhythm and you want to reset. Think of it as pressing the reset button on your computer. And then the other questions are all comments about how great I am and how great my analogy is. So I'm just going to take that with the humility that I am endowed with. So moving back to sinus and AV node disease. Now imagine you are a very unfortunate person. You've had a massive right-sided heart attack and you have wiped out not only your sinus node, but your AV node. You are in big trouble. Not only can you generate heartbeats from your sinus node, you can't even pass those signals down to the ventricles, to the main pumping chamber of your heart to keep yourself alive. What on earth are you going to do? Well, don't worry. You've lost your main pacemaker. You've lost your backup generator, but you have a plan C. You have a backup pacemaker. And it looks like this. We have a slow rhythm. We have a broad, weird-looking QRS complex. Remember what I said about QRS complexes? Either they are, if they're very broad, they're either coming down the normal way from the sinus node, but going through a bundle branch block, or they are being generated within the ventricle themselves. This guy has no P waves. There's no sinus node firing. So that means this person is generating their own impulses from within the ventricles, like we saw with ventricular tachycardia back in the tachy section with the VT, except this is very slow. And that's because this is what we call an idioventricular rhythm. This is your last chance saloon. If you have lost your sinus node and your AV node, you can pace your heart using your ventricles, using the Purkinje fibers. What you end up with is a rubbish pacemaker. It can only really pace about 30, 40, maybe 50 beats a minute. It just gives you enough time and enough blood pressure to drag yourself into hospital and get a pacemaker fitted, but it's an evolutionary trick which sometimes works. And you'll notice on the ECG, because of the very slow, broad-looking complexes, ventricular complexes. So moving on to part 4, I'm talking about broken circuitry. I'm going to do a quick dip into the chat box. Is Mobitz type 1, I'm being asked via Facebook, is Mobitz type 1 the same as Venkaback? You've got it. That's exactly is. So you might see people in Mobitz type 1, you might see people say, hey, they're Venkabacking. We love to turn single words into verbs in medicine. So Venkaback is another name for Mobitz type 1. Good question. How long can an idioventricular rhythm last for? I'm being asked. Kaylee, it lasts for maybe a couple of days, and they are not pleasant days. You will struggle to generate a blood pressure of more than 90, and it is not a long-term solution to the problem that you have. No further questions, so back into the slide we go. Broken circuitry. Let's have a look at this. This is basically about blockages. So imagine if you've developed a horrible disease and you've blocked your right bundle branch. You've got a working sinus node, a working AV node, your left bundle, which is working fantastically, but your right bundle's gone a bit weird. You end up with a right bundle branch block, RBBB morphology, on your ECG. And they're really easy to see because you just see them in V1. So have a look at V1. Not many things that give you a positive V1, but right bundle branch block will. And you get those little rabbit ears, positive complex. And that's how you spot a right bundle branch block. What causes right bundle branch blocks? Disease of the right bundle branch or right heart strain. So you might see it if someone's had a massive PE, or maybe someone's got horrendous cor pulmonale because they've got lung disease. You'll see right bundle. What about left bundle branch block? You might see a left bundle branch block if you have disease of your left bundle. Left bundle branch blocks are dangerous because your left bundle supplies your left ventricle, the main pumping chamber of your heart. So whether a right bundle branch block can be safely ignored, and in fact, is considered physiological in healthy young people. Left bundle branch block is always a big warning sign. It's always pathological. Looks like this. Again, you spot it in V1. Go to V1 to look for your bundle branches, and you get a big, deep negative V1 with a broad QRS. QRS more than 3 small squares, more than 120 milliseconds. And you can see that here. So that's how you look at your bundle branches. You look at the V1 basically. Positive V1, rabbit ears, right bundle, big negative one, sometimes looks like a W, left bundle. What about if someone only blocks the anterior fascicle of their left bundle? The left bundle divides into anterior and posterior fascicles. And sometimes you get people who only block the one. You actually get this, a left anterior hemiblock. Left anterior hemiblock looks like, on an ECG, looks like a left axis deviation. And you can see it by looking at leads 1 and 2, the limb leads. And you can see it the way they are looking away from each other. Lead 1's going up, lead 2's going south. Left anterior hemiblock causes a left axis deviation. So now you're going to say, well, how do you work out axis deviation? I'll show you the cheats way, the quick way that I use it without having to work out a graph or anything like that. All you got to do is look at lead 1 and lead 2. You've got 2 upgoing positive complexes. You've got a normal axis. You have a negative 1 and a positive 2. So the complexes are reaching down, trying to touch each other. That's a right axis. And you can sort of remember that because you can maybe draw the letter R around them, kind of, which is how I used to remember it at med school. That's your right axis. Right axis is caused by right heart strain, just like your right bundle branch block was. So cor pulmonale, big PEs, things like that. You've got 2 complexes pointing away from each other. You've got your left axis deviation, which is usually caused by left anterior hemiblock or left anterior fascicular block. So your left axis. If you've got this, where both 1 and 2 are negative and pointing down, you have made a mistake in your ECG and you probably got the leads switched to the wrong arms, because that is the impossible axis. Or the patient has dextrocardia and you're the first person to make the diagnosis. But if you see this axis, go back and check your limb leads. They're probably on backwards. You will see this quite a lot. when ECGs are done on the fly in medical practice. And you're looking at the heart backwards. Right. Now, imagine if you were unfortunate to have a right bundle branch, a left anterior hemiblock, and a left posterior hemiblock, usually due to horrible coronary artery disease and big ischemic patches affecting your circuit board. This is what we call trifascicular block. You've lost 3 fascicles, the right bundle, left anterior, left posterior. And trifascicular block looks like this. Look at V1, positive V1. What does that mean? Right bundle branch block. Look at the axis. 1 and 2 looking away from each other. Left axis deviation. And finally, look at the PR interval. You've got first degree heart block, longer than 5 small squares, longer than 200 milliseconds. So when you see this is a great thing to pick up. A patient who's got right bundle branch block, left axis deviation, and a long PR interval, first degree heart block. This is trifascicular block. They block 3 fascicles of their heart. Why is this important? Because between 1 and 5% of these people within a year go on to develop complete heart block and need a pacemaker. So this is a really, really important sign to find. So if you do find a right bundle on an ECG, have a look at the axis and the PR interval, just in case you're spotting a trifascicular block. Okay, what I want to do now is quickly run through some cases that are real cases which happen to me in my clinical practice. So they're photos I've taken on my phone of interesting ECGs, so the quality might not be great, but have a look at this. Imagine you're on the ward in a hospital, crash call goes out, your pager goes off, you go running to the emergency medical call, and you find a 69-year-old gentleman. And the patient was found by the FY1 to have a heart rate of 150 beats per minute and a very weird ECG. But the patient is sitting there in bed looking okay, looking fine. But the FY1 was worried and puts out the crash call. And here is the ECG. Remember Lovell's first law. What does this ECG show? My first law, can you remember? Have a look at this ECG on admission. Well, actually look at this ECG. First of all, we've got someone who is tachycardic. Is it broad or is it narrow? We ask ourselves. And we ask ourselves, is it regular or irregular? That's what we do with tachycardias. Well, it's broad, more than 3 small squares in the QRS complexes, and it's regular. And my first law was, whenever you see a broad, regular tachycardia, you think, is this VT? Is this a rhythm that's going to kill them? And yep, 3 people in the chat box have proudly submitted VT as the correct answer. So that's why the FY1 pressed the crash call. They saw the ECG and they thought, uh-oh, ventricular tachycardia, is this patient going to arrest? Perfectly appropriate to do. So then I came along and I had a look at them and I had a look at the admission ECG as well, which looked like this. I thought, actually, when he came in, he had a broad complexes, QRS, they were broad, which means either they're ventricular complexes or he's got a bundle branch block. And there seems to be P waves. Look at the rhythm strip along the bottom. So it's sinus, so it can't be a ventricular rhythm. So this is someone who's got a background of known bundle branch block. Is it left or is it right bundle branch block? Let's have a look. It is probably right, because I would say that V1 was just about more positive than negative. There's also a left axis deviation here, but there's a normal PR interval, so it's not trifascicular block. But it's someone who had a right bundle branch block already, and then they went fast. So it looked like VT. So we're going to de-escalate our panic levels a bit. I don't think it's VT, but then what is the rhythm? This was the rhythm. So remember the second law. I then realized that this rhythm was dead on 150 beats per minute. What's Lovell's second law of tachycardias? Atrial flutter. Atrial flutter. This is a patient with a background of right bundle branch block who then went into atrial flutter with a 2-to-1 conduction on the ward, producing a regular broad complex tachycardia, which looked a bit like VT. And that's what this case was. And I'm being told to tell you this session may run a little bit over an hour, and just to let you know, but I might still get in on time. Case number 2. This is a routine ECG done for a 21-year-old female in a pre-assessment clinic who's awaiting knee surgery. She's never had a chest pain or a palpitation or a collapse in her life, no cardiac history, but they all get an ECG before they have an anesthetic, and it looks like this. Now, this is a funny one we haven't actually covered yet today, so I'm quite pleased to tell you about it now. The rate appears to be not fast, not slow, it's okay. The QRS complex, is it broad or is it narrow? It's kind of wonky looking. It's broad at the bottom, but narrow at the top. But if you look at, there's always someone who guesses this, and someone has guessed it in the chat box, but let me have my big reveal. If you have someone who has this funny up slurring of the QRS complex like this, it's called a delta wave, and it's a pathological sign of a heart condition. And that heart condition is called Wolff-Parkinson-White. And I'm going to show you exactly what I mean in more detail. So first of all, notice, have a look at, say, V2 and V3. You see how that positive QRS complex doesn't go straight up. It sort of curves up a little bit as it goes up. And look at the PR interval. Look at the PR interval in V1 or in lead 2. Very, very short PR interval, shorter than usual. And that's because people who have Wolff-Parkinson-White have a funny little accessory bundle. It's a shortcut, really. It's a little accessory pathway of nerve fibers. And it's a shortcut between the AV node and the ventricles that bypasses the usual bundle branch blocks. And it's fast. It can transmit signals much quicker than the usual way. So what you see in a normal QRS complex is a P wave, because the sinus node fires. And then as the QRS complex hits, the PR interval is very short because the electrical signals go flying down that accessory pathway and activate the ventricles before the usual pathway down the bundle of His and the left bundle and the right bundle. And so you get this slight upslurring of the wave as the fast fibers get there, and then everything else catches up. It's called delta wave. The accessory bundle is called the bundle of Kent, for those who are interested. But this is an example of someone who has an accessory pathway, and it's called Wolff-Parkinson-White. And usually Wolff-Parkinson-White sits very benignly, and people don't really have a problem with it until that little accessory pathway gets its idea in its head that it wants to start transmitting signals backwards. Imagine you have an accessory pathway that transmits signals this way. What the patient develops is something called a reentrant tachycardia, where signals just keep flying and flying around, and they get stuck in this horrible tachycardia, which they can't come out of. Remember with SVT, AV nodal reentrant tachycardia, you have a teeny little microscopic reentrant circuit in the AV node. For Wolff-Parkinson-White, you've got a great big macroscopic self-fulfilling prophecy of a pathway that keeps going round and round. So that's why if people are found to have Wolff-Parkinson-White on routine ECGs, they have that electrical accessory pathway destroyed by very careful ablation. Imagine this case, an 82-year-old woman with worsening breathlessness, and she can't even take a few steps, and she's got no chest pain. And her ECG looks like this. This is a real case that happened to me. That's why the quality is not so great. So I looked at it and I thought, well, okay, sinus rhythm, because there's a P wave. Broad QRS complexes. Somebody, not me, someone else, had written M above the complex on V1 to make everyone aware that they'd spotted the patient had a right bundle branch block. Fair enough, we've got a broad QRS complex there with a positive V1. And I thought maybe sudden onset breathlessness, maybe she's had a pulmonary embolism. That would explain a right bundle branch block morphology. And then I had another look and realized that she has a very, very exciting ECG finding, which you might read about and you don't see very often, so that's why I took a picture of it. She has something called S1QT-T3. It's a diagnostic ECG finding of PE, and it's very exciting if you see it. And it means the patient has an S wave in lead 1, limb lead 1, up. They've got a Q wave in lead 3, going down. And they've got an inverted T wave in lead 3 as well. And when you see S1, QT, T3, you can say PE pretty confidently. It's very exciting to see. We're going to quickly dip into the chats. Lots of people saying Wolff-Parkinson-White and getting it right. Only 20% have this finding. You're right, it's not so specific, but it's very exciting to see. The commonest finding in the PE is a simple sinus tachycardia. And that's why I say you will see S1, QT, T3 written about a lot, but you won't see it very much. When you do see it, it's very exciting because you know that the patient has a PE. You want to have another look at it? Someone wants to have a look at it? Let's have a look at it again. So we're looking at lead 1 and lead 3. Lead 1 has an S wave as the first thing that happens to it. Goes up. Because remember, Qs go down, Ss go up, Rs go back down again. Then going to number 3, they have a Q wave. The first deflection of the QRS complex is a Q going negative, and they have an inverted T wave. That's S1, QT, T3. Case 4, a 65-year-old gentleman with recurrent syncope. Keeps passing out. Physical examination, unremarkable except for an irregular heartbeat. And his ECG looks like this. Spot diagnosis, all righty. Anyone can look at that and say, okay, that's irregular. Something weird's happening in the middle. There should be a heartbeat. There should be a QRS complex and it's not there. Let's inspect the P waves and the QRS complexes. So we have P wave, QRS over here. Slightly longer PR interval over here. Slightly longer PR interval over here. And that P wave doesn't go anywhere. What is the rhythm? Okay, someone said 2 to 1. So what's happening here is the QRS complex is coming home later every night, later, and then one night it doesn't come home at all. It is Mobitz type 1. So it's the first type of secondary heart block, Mobitz 1. You get the Venkerbach phenomenon. You get a lengthening PR interval and then a P wave is dropped. Case 5, ECG of a 77-year-old male with recurrent syncopal attacks. I threw this in because this is a really good thing to be able to recognize on ECGs. Have a look at the complexes. Have a look at the biggest ones, which seem to be in V3. Do you see that the QRS complex is initiated by a funny little black line, a vertical black line, a spike? Have a look at V4. You can see again, there's a vertical black line and then the QRS complex happens. And if you actually look along the top of the ECG, you see little black dashes. This is the ECG telling you it's sensing a pacemaker. And you don't want to miss this sign. This is a man who's got a pacemaker, which is pacing his ventricle, which is why a pacing spike, that little line of electricity, causes a QRS complex to happen. It's causing a ventricular beat to happen. So this is something you want to know about. This is what pacing. A lot of people walking around with pacemakers in situ, and this is what it looks like in ECG. A little spark of that electricity, which is presented by a line which precedes the QRS complex and then a complex. There it is there. And there it is along the top. Case 6, a 64-year-old male with severe heart failure due to cardiomyopathy, hypertension, and a previous MI, presents with left thoracic discomfort and palpitations and has this ECG. What are we going to do about this? It's very fast. Is it regular? It's regular. Is the QRS complex broad or is it narrow? PS has put in the chat box, oh dear. Why oh dear, PS? Is it because perhaps you have seen that the patient may not have a pulse? Yes, this is ventricular tachycardia, VT. My first law of tachycardia is broad complex irregular tachycardia. Does the patient have a pulse? And is this VT? And it looks like this patient went into VT right there and then because you can just see the beginning, a little QRS complex, which looks normal. Near the end now, guys. A 69-year-old female on the CCU suddenly develops hypotension, chest pain, and tachycardia. She's 3 days post-heart attack and she had a triple vessel angioplasty. Now, this is interesting. Have a look at this. This is someone who's got a very bizarre ECG. The QRS complexes look weird, but regular, but weird and broad. What does it look like? This is a type of VT. We know it's VT because of Lovell's first law. It's a broad, complex, regular tachycardia. It looks weird. But you'll notice that the height, the size of the QRS leads go bigger and smaller like this. it is VT, you must take all the same precautions you would in VT. You would check for a pulse, but it's something called polymorphic VT. The VTs I've showed you before are monomorphic. This is polymorphic, and its other name is torsade de pointes, twisting of the points. You might see it called torsade de pointes, but this is a polymorphic VT, which is just as dangerous as VT, and the patient may or may not have a pulse. Right, case 8, an 84-year-old man brought in by ambulance with a bradycardia, and he collapsed at home and has been drowsy ever since and is hypotensive. And here's his ECG. So it is slow. Looking at the strip, it looks as though the QRS complexes are caused by a P wave, which is appropriate, but there seem to be a lot of P waves before a QRS complex happens. So what is this rhythm? We look at the bottom, we see P wave, P wave, P wave QRS with a weird inverted T wave. P, 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 QRS. P, 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 QRS. Very fixed, 3 P waves to 1 QRS complex. This is the QRS complex is only coming home from work every third night because the relationship has fallen apart. This is 3 to 1 Mobitz 2 second degree heart block. And this patient needs a pacemaker. Okay, the last 3 ECGs and we'll get you to 30. Spot diagnosis. This is an interesting ECG. It is tachycardic, it is narrow complex, and it is regular. Now we had 3 things in our narrow complex regular tachycardias. We had sinus, which should show P waves. Which are difficult to see here. Maybe the patient has P waves in V1, I'm not convinced. We had AF, which would be about 150. This is faster than that. And we have SVT, which is usually very, very fast and no P waves. So I would prefer SVT for this rhythm. But look at the height of the QRS complexes. Look at the bottom strip. Notice how you get a tall one, a short one, a tall one, a short one. This is called electrical alternans, alternating electrical amplitudes of each QRS complex. And it's a sign of a big pericardial effusion. The heart is swinging back and forth in a big balloon of fluid in the chest. It swings forward, your ECG studs pick up a tall complex. It swings backward, they pick up a short one. Big one, little one, big one, little one. As the heart is swinging like a pendulum inside a big ball of fluid, this patient needs an urgent echo and possibly a pericardiocentesis. Have a look at this ECG. So the main, this is a regular narrow complex with a normal rate of about 300, 151, about 75 beats a minute. The ST segments look a little bit off. Is it snails? Is it an ST segment elevation? Because I see ST segment elevation in V2, 3, 4, 5, 6, and in lead 2, and maybe in AVF as well. Is it possible to have full thickness infarct across 2 or 3 different vessels of the heart at the same time? Or could this be something else which is causing global ST elevation? A lot of you are guessing the answer in the chat, and the answer is pericarditis, inflammation of the pericardial sac. You might hear this phenomenon being called saddlebacking because the slopey, the sort of concave ST elevation looks like the back of a saddle. Or maybe you might prefer to think of it as half of a smiley face. It's sort of a carved out. But when you have global ST elevation across all of the precordium, which you think, well, it's very unlikely having a triple vessel STEMI at the same time. This is a sign of pericarditis. And our final ECG shows this. You don't want to miss this one. We've got a tachycardia. We've got very abnormal, broad-looking QRS complexes. But have a look at those T waves. See how tall and pointy those T waves are. Rebecca has guessed it. This is the tall, tented T waves of hyperkalemia. Hyperkalemia can cause all kinds of arrhythmias and also death. And usually the earliest sign are these very pointy T waves. And you might say, well, how pointy is a tall, tented T wave? It should look like it would hurt if you sat on it. It's the basic way of remembering what they look like. Very, 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 very pointy. That is all your ECGs. You've seen 30 ECGs. You have moved from maybe the bottom of this There's post it to the top where you can actually now see what a tombstone ST elevation of an anterior infarct might look like. And hopefully things are a lot less mysterious when it comes to arrhythmias than they were before. I have exactly hit 1 hour's time, and I'm going to have a very quick look in the chat box to see if there's any questions I can answer before I go. Could you go over trifascicular block? Maybe in 10 seconds, and then lots of thank yous. The only thing I'll say about trifascicular block, I won't go back to the screen, is it's 3 things on your ECG. Right bundle branch block, positive V1 with a broad complex. Left axis deviation, leads 1 and leads 2, the complexes are looking away from each other. And a long PR interval, first degree heart block. When you see those 3 things together, the patient has blocked 3 major fascicles of the heart and may go on to develop the need for a pacemaker in the future. Okay. There are a lot of questions now, and I don't know how, and lots of thank yous. You're very welcome. I hope you enjoyed it. I think I'll leave the questions there for now because I realize I've kept you here for an hour. If you want to find me on Twitter at Dr. Dr. Ben Lovell, you can ask me questions there. I guess I'm going to hand back now to the team at Becoming a Doctor and see if you have anything else you want me to do.
No, we're good. That was a great lecture. Like I was glued to the screen the whole time. Thank you so much for explaining a really complicated topic really easily. And thank you everyone for tuning in. And we'll see you next time.